Well, it's 12:03 and we went down to 13 instead of 14. So let's just begin to get this data users group session underway. And anybody can join in. And of course, we'll make the deck available. So welcome, everybody. This is the April 2026 quarterly all payer claims database data users group webinar. This is our 26th session. My apologies for having to cancel the January 2026 data users group session. Hopefully this session will make up for it. A lot of what we were going to talk about then, we're going to talk about now. If you don't know me, I'm Kenley Money. I'm with the Arkansas Center for Health Improvement, or ACHI, and I manage the team administering the data assets in the Arkansas Healthcare Transparency Initiative, or HTI, and that includes the APCD. Before we move forward, let's have some housekeeping rules. Feel free to type your questions in the chat at any time, and we'll address them as we get them. Cecilia Kirst, our infamous project manager, is online, and she will be able to pick them up and remind me to look. At the end of today's session, as I said, we will provide a link to our service desk application where you can enter any question or topic you're interested in discussing. The APCD can be very complicated, so if you have an idea for an agenda item, please let us know. The link to this deck and the recording of this webinar will also be made available to you. The webinar records for all presentations for the past data users group are on our website. So if you have a particular question, I encourage you to go look there. Maybe we've already addressed it. And if not, then reach out to us and we can address it directly. I expect we'll have some time at the end if you want to save your questions till then or ask something else. And our next data users group will be July 15th, 2026. We hope that you find today's session helpful. The agenda for today, or the introduction, we are going to talk about the MEST data enhancement. We've talked about MEST before, but we have an enhancement that makes it much more usable. Then we're going to talk about Medicare enrollment data, how to identify fee-for-service versus Medicare Advantage and dually eligible beneficiaries. We've talked about Medicare in the past some, but recently we've had to use the data and identify these types of beneficiaries, so we thought we'd share some methodology with you. And then, of course, the latest release, we have a new release and data tips. I am your speaker for today. No guest today. Perhaps next time we will have a guest. First, a bit about ACHI. Most of you I have spoken to before, looking at the list of attendees. But a little refresher. The Arkansas Center for Health Improvement, or ACHI, we established it in 1998, and it created a much-needed intersection between research and policy. We are nonpartisan, an independent health policy center dedicated to improving the health of Arkansans. We have proven experience in the management and integration of health data to support research and health policy. That's the high level. The HTI was the result of Act 1233 of 2015. It was created through that act and has become the premier resource for administrative health data available for research and analysis in the state and other states too. Act 1233 also mandated the commercial and state-funded entities mandated that they submit claims to the APCD. More about that in a minute. The HTI management and oversight. The Arkansas Insurance Department is the authority. They're the ones who sign the data use agreements, who approve projects, etc. And ACHI, we're the administrator. For all intents and purposes, we are the vendor, but we are also one of the primary users of the APCD and a great source for best practice and methodology. The HTI, it integrates data sources to increase healthcare transparency, better understand costs, support health system transformation efforts, and it includes the APCD, which is made up of fully insured data and the state entity data, and then non-claims-based data, which includes birth certificate data, death certificate data, et cetera, et cetera. In fact, let's look at a picture. This is a high-level picture of what is in the Healthcare Transparency Initiative. That top gray box is the APCD, and it includes commercial fully insured, state and school employees, Medicaid and Medicare fee-for-service. And I should put in parentheses, Medicare sourced from CMS, ResDec, as well as Medicare Advantage claims from fully insured carriers like Blue Cross Blue Shield, etc. The commercial fully insured, what we don't have are self-insured, self-pay like Walmart. We don't have VA data. We don't have TRICARE. And of course, we don't have a lot of insight into the uninsured. But now with that segue, let's look at the representations of the file types below the big gray rectangle. You see they're listed the birth certificates, death certificates, cancer registry, workers' comp, medical marijuana card holders, and hospital ED discharge. The hospital and ED discharge are unique in that the only data we get from those sources is for self-pay and uninsured. Of course, it's very targeted. It's hospital discharge data and emergency department data. But if your study requires some sort of visibility into the uninsured, this is the best source to get it in the HTI. The linking key, that which links all these together, is the study ID, sometimes called the hash ID. At the end of this presentation, I always ask you to go look at the data attributes deck that gives definitions of what these are. Some of you have been on these webinars forever, so you already know the difference. The study ID, where the hash ID is that 44 to 45 character value that has multiple numbers and letters and symbols that represents the member's last name and date of birth. And when you concatenate gender on that, you get a really clean, tight matching key. The only problems come with same-sex twins, or if women change their names when they're married or divorced. The study ID is the hash ID plus the date of birth. Every now and again, they don't align. The dates of birth in a carrier system don't align. So sometimes for a tighter match, we will concatenate the date of birth to that hash ID plus gender. By and large, it's fine if you don't do that. But if you want to see if you can get an extra few records joining, maybe that would work for you. The study ID instead of the hash ID. Anyway, all that's in the data attributes deck. All of them come together in our HTI data repository, linked by the study or hash ID. Okay, with that intro, I'm going to go off camera so you won't be distracted. Let us talk about our first subject today, and that is the MEST table, or Member Enrollment Selection Table. We talked about this about a year ago in a previous webinar, Data Users Group webinar. Some of this will be familiar, but when we started using this, an external researcher started using this, they asked a question that it couldn't answer without a significant, labor-intensive, not always accurate workaround. So some of this, well, let's just move forward. So you might recall when we decided to build this table, we did a survey to say, what is your biggest challenge in using the HTI or APCD data? And the biggest challenge was how to get the enrollment data manhandled so that you could easily find these sections: enrollment periods, breaks in coverage, coverage transitions, payer and coverage types. And it does that. But for the first time, the question that was asked of the data when we released it initially was, okay, I get all that. I know when a person was enrolled. I know when there was a break in coverage. I know the general category of coverage. Was it commercial? Was it QHP? Was it Medicaid? But what type of coverage had they bought for that time? In other words, if I had someone who had a commercial plan, for a period of time, did they just buy medical? Did they just buy pharmaceutical? Did they buy both? That's the question that the previous test or file couldn't answer. What were the coverage types? So This we summarized about a slide ago, continuously coverage transition from one payer to another, specific types of coverage and what they are. So let's move on. I want to look at the data. For those of you who have used our data, you know that this is basically what the member data looks like, the enrollment data. And this is what we used before in the first version of MEST, but we have since added this information. And this information means that for this user in this plan, at this time period, their plan included medical and pharmacy, but not dental. And this plan, Medicare Advantage, you see it's got different dates, included medical and dental. So this was the information that was missing. So what we can do now is we have a row for the member, the payer type, the year, the enrollment string, the months covered, and what they were enrolled in for this period of time for that commercial plan. And same with the Medicare Advantage and so forth. So we have some more examples to better translate what you're seeing. This has proven invaluable. This is how, for those of you who are unfamiliar, this is how you read that enrollment string. So each one represents a month in the year. This is the year. And so this particular example, the person was enrolled in a commercial plan for these months, 5 months of the year, and they happen to be enrolled in medical and pharmacy in that particular time for those months. Okay, so let's read them. These MEST records represent the following enrollment for this member, this made-up member. And you remember, you concatenate the submitter and the member ID. The unique ID is not, or the unique ID, aka study ID or hash ID, is not part of this. This is all at the member level at the plan. So for this particular person, they had 6 months of medical and pharmacy coverage between January and June of 2021. And that is row 1. See, medical pharmacy, first 6 months of that year. The second, 6 months of medical coverage between July and December of 2021. So they changed. They dropped their pharmacy for some reason. And then the next one, 12 months of medical pharmacy and dental coverage in 22. So, and this is rows 3, 4, and 5. So they had, some carriers have split them out, you see. But by payer, I'm sorry, let me back that up. This is split out by payer type. So you see, this is QHP, they had medical for those 12 months. This is PBM, they had pharmacy for those 12 months. This is dental for those 12 months. 3 different plans, but you can summarize that all up to say this person had this coverage for all of 22. So you can ask more specific questions. There are more examples in here that illustrate in more detail, that address some of these nuances that we just talked about there. See. And if you want, so member with study ID ABCX2 equals M meets the criteria for 12 months continuous coverage. I said earlier that the study ID didn't matter, the hash ID, study ID. But in this case, you can roll it up by the study ID, and that helps cut across the different plans from different carriers. This person has a gap in coverage between 2019 and 2020, all these right here, those zeros. And so that's how you can use the enrollment string. All right, there are more examples here. Let's see here. Oh, well, the criteria that this references is on the page before, but I'm going to move forward because I think I'm optimistic that this makes sense, that you can find the types of coverage based on enrollment string by year and payer type. Okay. After the study has been determined, users can select the medical pharmacy and or dental claims that have the matching SEIDs. So you would, if this is the coverage, this is who this person is, you would go down to the medical claims because they have medical coverage, and pull all the records that have the same SEID right here. And then you can pull all that. Same with pharmacy. They have pharmacy coverage. Take this right here, go to the pharmacy table and get all that. This particular one didn't have dental, so I didn't give that example. So applying this table to research enables the data user to determine easily and accurately when members' enrollment began and ended, as well as their payer type and type of coverage, and to ensure that projects include qualified members whose enrollment data may span years, and identify transitions in member enrollment at the monthly level for enhanced visibility. So for those of you who are with who do your work through the Arkansas Biosciences Institute, the latest data database data has been delivered to you last week, and this file is included. So if you have a chance to have a project that requires the identification of continuous coverage at this level, ask for it in your project data. Okay, are there any questions at this point? I don't see any. All right. Okay. So let's talk about Medicare enrollment data. Now, first, I will say that the Medicare data shows up in two ways in the Healthcare Transparency Initiative. ACHI acquires a copy of Medicare fee-for-service data from ResDAC, CMS ResDAC, the Research Data Center. And many of you may have used it in that form where if you, under a research DUA, and it comes in many, many tables. It is not an APCD format, but it is very, very rich. And it's highly scrubbed and cleaned. The data we get from there is always at least 2 years. Well, it's 3 years old now because we've just put up 2023. So it's pretty clean, and it's got some logical ways to join the tables that are pretty straightforward. These data include beneficiary data and claim level data broken up by many categories like inpatient, outpatient, hospice, SNF, professional, pharmacy, etc. We also get Medicare data through the private carriers, the fully insured carriers that give us these data, but that data is Medicare Advantage data, and that is generated by folks covered with Medicare who have selected Medicare Advantage to have a private carrier manage their insurance claims. There are all sorts of ways to get Medicare data, which is almost its own session. But for now, the Medicare Advantage data that comes in the APCD format from the private carriers can be identified using the field called ME001 CAT. It's in the data dictionary, and you would look for the value MCR_ADV, and you would get a snapshot of that activity in the shape of an APCD claim or member record. But if you wanted to get it from Medicare ResDAC itself, you can, because Medicare Advantage enrollment data, not the claims so much, but the enrollment data is included in the data we get from ResDAC CMS. So now, not everybody has access to that version of the Medicare data. Only the data users that are associated with state agencies like the Department of Health, DHS, ABI as part of UAMS, a independent data requester that wanted access to Medicare data, fee-for-service data like that, they would have to go through ResDAC to even get close. So we advise that's their choice, but generally we can say that the Medicare Advantage data in our APCD that comes from private carriers is sufficient to address their particular aims. But if you have access to the Medicare data fee-for-service through the APCD HTI, or you buy it from ResDAC directly, hopefully this information will be helpful to you. So this slide sums basically what I just said. If you've ever looked at the Medicare beneficiary summary table. That's where you're going to go for this. It's a very wide table, very wide. And it has one row per beneficiary per year. And it generally doesn't change once that year is over, which is one reason why the Medicare data is so old. We don't get it that often. But if you have access to the layout, and when you get this deck, there's a link to the layout for the Medicare data that we have. You are welcome to look at that layout, all the layouts at your will, even if you don't meet the requirement of being associated with the appropriate state agency to get access. You can look at it, no problem. But it's very wide, and within it, you will find these 12 fields: HMO, IND, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And these represent months, January to December. And the intent is that if you had Medicare fee-for-service in January, there would be a particular value. But if you had Medicare fee-for-service, Medicare Advantage in January, you would have a different value. And private carriers have to talk to CMS. They have to report it. So the two align very well. So here are the values. There are a lot of, if you go out, we're going to do a pro tip later. If you go out on to the internet and look for the value definitions for these fields, it's going to give you a lot of info. But in summary, these two fields, O and C, will give you what you want. And this term, in these terms, Medicare HMO is the same as Medicare Advantage. So here's some examples, and this is real. These came directly from the data. This particular person right here, this beneficiary, had Medicare coverage in 2014, and they were enrolled in Medicare Advantage the entire year. You can't be in fee-for-service and Advantage at the same time in 1 month. This particular person had an enrollment in 13 and 14. You can see they were Medicare fee-for-service all of 2013, and then through March of 14, and then the rest of the time was Medicare Advantage. There are all sorts of reasons why people can go back and forth. So it doesn't surprise me to see all sorts of varieties. So let's move forward down here. This particular person had enrollment in 2013, had fee-for-service through March, had 3 months of Medicare Advantage, and finished the year fee-for-service, and so forth. This particular person, you can see fee-for-service where the zeros are, Medicare Advantage, fee-for-service, and then this person had fee-for-service the whole year. So as you look, if you have access to the beneficiary summary table in whatever data you're accessing, and you look at these fields, you can begin to you can know exactly when they had fee-for-service or Medicare Advantage. I almost said and/or, but that's not correct. Fee-for-service or Medicare Advantage. This slide supports the slide we just talked about. So if you download this deck, you'll have it. Now, there are a lot, if you look at that beneficiary summary table, there are a lot of different field groups that have 1 through 12, lots and lots. And again, like I said, you probably need a whole class on just that. But there are some that reference Part D and Part C, and it just goes on and on. But the ones we use the most, ACHI uses most for their analysis are these: the Medicare Advantage, or the HMO indicators for Medicare Advantage and fee-for-service, and dually eligible. This is a real quick way to identify someone who is dually eligible for Medicare and Medicaid at a particular time. You can sort of pull that data out of the Medicaid data in the APCD, but this is I'm going to say it's easier to manage, and it's more straightforward to do. Now, here's the thing. Here's a teaser. You can have HMO, you can have Medicare Advantage or fee-for-service and be dually eligible. Let's look at that. Here are the values that we use to identify dually eligible individuals, beneficiaries. In our work, we haven't had to really break these out. We just need to know that it's present. But depending on your study question, you might need to know the specifics of each of these. So here's an example. This person had they had Medicare fee for service the whole time, and they were duly eligible for 11 months until they had a 9. Is that right? Let's go back and look. Yeah. So they were 1s and 2s, and then this 9 over here, except for December. I didn't include an example, but there are some that have they have 3 months of Medicare Advantage, and then they go back just like we saw before, but you will see that. So as you build your analytic data set, the data from this beneficiary, know that there's one record. So these fields are going to be stacked at the end. They're going to be behind these fields. You'll see them all in one record. So you'll have to cut and dice your data accordingly to find the overlap. Checking for questions. Nope, none. Okay. The layouts for these are here. Let's see. I did not preload that. Hang on, let me unshare. Okay, I'm going to reshare. Okay. Now you should see this is a page in our data dictionary section of our website, and it's Medicare Data Dictionary Resources. The data element list is here, and then there are some other resources, online resources. Let's see if we can get here without let's see. Ashley, are you able to see data request data element lists?
Yes.
Okay. This page will take you to all the layouts, and you can download and look at them. Let's try claims-based. Where's Medicare? Medicare. Oh. Stand by. I'm going to stop sharing. It's worth it, ultimately. Ultimately. But... Okay. All right. Resharing now. All right. You should see an Excel spreadsheet. And no, you don't. Not yet.
Here it is.
Now you can see an Excel spreadsheet. Yes.
Yes.
Okay. All right. So this is the data dictionary, or the layouts for the Medicare data you can download from our website. There's some instructions and high-level definitions, but this is the layout for the Medicare beneficiary summary table. And you can, like I said, there are many different categories that have the 1 to 12. This is state and county FIPS, because they recognize that a person moves at any given time. So Medicare status, enrollment, this is what we looked at, HMO, product contract ID, Part C. I don't know the nuances of all of this. I'll just tell you. Yeah. So if you ask me, I would have to start digging, and then here are the duly eligible status codes, and all these layouts and so forth. So these layouts are at your disposal. The layout that we receive, that we just load straight up, is pretty common. There are not many changes from ResDAC, but if you do order data from them, you certainly double check, but you can download this as a starting point. All right, I'm going to unshare again and go back to my deck. Okay, reshare. Oh. Okay. Now, there we are. We've shared again. So here's a pro tip. There are 59 tables in the Medicare subscription, or the data set, 59 different ones. And frankly, I don't have every single data data element documented. I have the names you just saw, but not the values because it's all online. There's not a great document that you can just download that has everything, but the pro tip I give you is I'm going to give you instructions on how to look it up on the browser. So you would find your field like HMO indicator 1, and you would just search for it, and it's going to pop up ResDec with that field or a definition of that field. And if you click on it, it's going to take you to a screen like this that will have the field name. It's there. And then the description and a comment and the values. And this is what I cut out and put in the slide, 2 slides previous or 3. So that right there is the best way to look up the definitions for Medicare data if you didn't already know it. So, okay, my pro tip of the day. Does anybody have any questions? No? Okay. All right. We have a new build. Yay. So we have now released, we call it 25B, and it has data through September 30, 2025. The data through December of 2025 will be released closer to the end of the summer, early fall. And that's because you might recall our data submission is staggered. So we just at the end of March, got the 2025, finished getting the 2025 data for all of 25. So probably if you get a cut of this data, there will be some data after September, but not enough to truly you'd have to figure that out yourself. The release notes are available here about things to think about in this particular build. There weren't too many things. The universe counts were always helpful, data dictionaries and tip sheets. And it says, what's new? A new PBM for the Employee Benefits Division. This is a little bit old news, but they have begun to submit more robustly. And so that's fall of 2020. Yeah. The next build will be expected to be available early fall of 2026. So the past couple of data users groups, I've talked about the new data submission guide, which are new requirements for submitters to send data to us. And there are a bunch more fields. I've talked about it a couple of times. And so recently a data requester was wanted to talk about what to expect with the new data and when they might get it. So the last data submission that we got end of March was largely in the existing format, which is DSG 8. And a few carriers were able to give it in DSG 9, but it's a significant piece of work to move from one version to another at the carrier. So we expect to receive through our data intake process the remaining files from all the remaining carriers in DSG 9 at the end of June. That does not mean that data will be available. That means that we will have it and we can review it. I am certain there will be significant back and forth with corrections and resubmission. So I do not believe that DSG 9 data will be available for acquisition until the spring of 2027. Now, by the fall, layouts will be updated. All the data requests, all the tools that you use to request data will be updated so that you can actually look at what's new and what's available. If you need to know ahead of time, just reach out to us and we can take you through it. But I wanted to set that expectation. Even though we're getting new data elements, we're going to be getting denied claims. It won't be ready for use until the spring of 27. It'll be great when it's there, but all right. Key changes. Data tips. If you're not on our data tip email, you need to let me know. We'll put you on the data tip email, and these are the ones that we had, I think, in the last email. So there's some new ones out there. You can go look. And as always, reach out to us if you have questions. If you need some tutorials, if you need help with anything, please reach out. And especially reach out if there's a subject you want us to cover. And there's the thing. Okay. We are at 12:38 without questions. We've made pretty good time. I'm gonna let me share video again. Does anybody have any questions or comments? No? All right. Well, all right then. I will take this opportunity to tell you that I am retiring at the end of June. So this is my last data users group. But don't worry, we'll still have them. So then I'm going to give you guys back 22 minutes. Thank you so much. Reach out with questions. Oh, wait, there's a comment. Whoop. Oh, thank you so much. I will miss you guys too. So, okay. Have a nice day.